So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So, topic for today's webinar is in women with subfertility. I welcome all the participants and request them to post their queries in the chat box so that we can have a short Q&A session at the end of the presentation. And now it's time to introduce our eminent speaker for the day. Dr. Vijayalakshmi Kandasamy ma'am. Madam is currently the professor, Department of Obstetrics and Gynecology, Chettinad Hospital and Research Institute. Madam is having more than 16 years of experience for both UG and PG students. And Madam is also the mentoring several batches of students in her institution. Madam is ex-ethics committee member, OXY. Madam's area of interest are high risk obstetrics, adolescent gynecology, infertility, and gynae endoscopy. So with this short introduction, I welcome you, ma'am, and I am under the session to you for further presentation, ma'am.
Thank you, Dr. Stalin, for those kind words of introduction. And I will just start my screen share.
Yes, ma'am.
Good evening to one and all. And at the outset, I would like to thank Shield Connect for this opportunity, for having given me this opportunity to connect with all my fraternity as well as to the doctors from other specialty as well. And as you all know, infertility or subfertility, as we recently call it, is something that is a burning problem. And it is, I would say, is on the rise. It's increasing, and several factors are the reasons for it. And the couple who have this issue or this problem are in a lot of emotional stress, and in fact, they tend to move from probably consultant to consultant in the hope that they can achieve the success, which is a live birth. But as you all know, this problem is multifactorial, and the problem may lie with the male factor or with the female factor. And in the female, it can be multifactorial. It can be problems at any part in the genital tract or the fine balance, that is the hypothalamo-pituitary ovarian axis that controls the or regulates the menstrual cycle. So let's move on to the topic per se. I would just like to give a brief overview, so more like a bird's eye view of the management of subfertility in women, because as such, this is a very vast topic and cannot be dealt with in 1 hour, especially so when we have to move into each of the factorial causes that leads to infertility. So by definition, inability of a couple to achieve a pregnancy after 12 months of unprotected regular intercourse is defined as infertility. And when the couple have never achieved a pregnancy, it's primary, and it's termed secondary when there is a previous pregnancy event. Even it can be a miscarriage or even an ectopic pregnancy. So let us review the physiology of the human female reproductive system. It is a very fine balance, which is the hypothalamo-pituitary ovarian axis, wherein the GnRH, which comes from the hypothalamus in a pulsatile manner, acts on the pituitary, leading on to the release of FSH, and this in turn causing the development of the ovarian follicle, and the growing follicle secreting the estrogen, estradiol, which actually several loops are there, the negative feedback effect on the GnRH, and the LH, which takes a surge just pre-ovulatory and leading on to ovulation. So this is a delicate balance which has to happen very appropriately for the couple to achieve a pregnancy. But we know that with the age, advancing maternal age, there's a decline in the fertility. And this steep rise in infertility or subfertility is seen after the woman's age crosses 35 years. So with the advent of women, career-oriented women, many of them try to push their pregnancies further down, and they are sort of voluntary planning, wherein they tend to delay their pregnancy, and this in turn can have a negative impact. So what are the factors affecting the management of infertility? Uh, the age of both the partners, the duration of their infertility, and any treatment that they might have undergone, previous treatment failure, and what is the particular cause for the infertility. So all these factors have to be taken into account. So it's a more like a vicious cycle. When the couple try very hard to conceive and put pressure on themselves, and the inability to conceive further accentuates their embarrassment and increases the stress level, and this overall increased stress situation can lead to reduced quality of life and infertility, adding on to this burden and leading on to further embarrassment, and interpersonal relationship may deteriorate, and probably depression. So the woman is always at the risk, or rather the embarrassment, and she bears the brunt or the burden of infertility. And in our society, as you can all are aware, that whatever may be the cause, the women tend to bear the responsibility for the infertility, and this in turn puts a great stress on her and in the relationship for the couple as such. Looking at the causes for female infertility, it can be anywhere along the female genital tract, as I said. It might be coming from inside out, ovarian causes, or tubal factors, uterine or cervical causes, vaginal and peritoneal causes. And a small but very significant portion of the couples may be affected by unexplained infertility, wherein everything is normal for both male and female, a husband and wife, but there is an inability to conceive. So just a schematic representation looking at the various causes for the female infertility. And you can see 30 to 40% of the causes are ovarian, and around 35% is tubal. So put together, ovarian and tubal factors almost account for 3/4 of the causes for female infertility, and much rarer are the uterine and cervical factors. Looking at the general factors, it might be diabetes mellitus or thyroid disorders, either hypo or hyper, adrenal disease, or significant kidney disease, liver disease, or even psychological factors. But these all do play a minor role. But diabetes is on the rise, and more so in women with PCO and with impaired glucose tolerance. So appropriate counseling and control of the diabetes must be done prior to initiating treatment for infertility. So when the couple come to us for their first visit, it's best to have both of them come at all visits. Many times the husband is off working, and the woman comes alone, and it's a difficult prospect just trying to explain everything to her alone. So as far as possible, as consultants, we must try to get them both initially, at least at the first visit, when we try and get a complete history. And very important that we be very empathetic to their condition, and take a thorough history, including a sexual history, and if required, probably talk to the wife first, or wife separately and the husband separately, and identify their problems before we go on to educating them about the fertile period and the various counseling that we are going to be giving them. So they should be evaluated together, and accurate information should be provided regarding, as I said, the fertile period, the act and timing of coitus, and if at all there is any therapy to be given, the nature of the therapy, its cost, and what are the other treatment options available. So all this should be explained to the couple, and also that there is a chance that in spite of all evaluation, it might turn out to be normal for both of them, and there is a chance that there might be a possibility of unexplained infertility. So the most important thing is we should try to gain their trust and see that they do not leave a particular consultant and keep moving from one to the other. And this in turn, reduces their chances for success. And it's important that they be very compliant to the advice that we give, especially regarding weight loss in women with the PCO, and talk to them about maintaining a positive attitude. That is very, very important. There are several studies which have been conducted as regards the effect of stress and its effect on the implantation, even in ART cycles. So probably a positive attitude and alleviating measures to alleviate their stress should also be given for the couple. And the counseling can help in identifying functional causes of infertility, such as even primary vaginismus. So if we look at PCOS, like I said, this PCOS or this condition has taken up almost epidemic proportions in our women. And as a first line of management will be to allow them or ask them to follow a modification in their lifestyle and give them a proper diet plan. And if they are found to be having a BMI more than, if they are in the overweight or obese category, reducing weight. So counseling regarding reduction of weight is very, very important. And the weight loss has multiple benefits. And one of the most important benefit is the increasing the levels of the SHBG, that is the sex hormone binding globulin, and it reduces the androgen levels and reduces the insulin resistance. And it also helps in mild hirsutism, and it also helps in uh, the woman to achieve a spontaneous ovulation also. So even if she were to lose 5% of her weight, there will be a significant improvement in her symptoms. Looking at the ovarian causes, management of ovarian causes. This is just a flow chart in a nutshell to talk about the various ovulatory disorders that might be afflicting the woman. Hypogonadotrophic, hypogonadic anovulation. So there, the entire spectrum of the hormones will be low. So she'll have low FSH, low E2, and she might even have amenorrhea. And the conditions could be as due to Kalman syndrome or anorexia nervosa. And in those women, GnRH and pulsatile administration of GnRH will be helpful in trying to achieve ovulation. And when the woman is eugonadotrophic and euestrogenic anovulation, that is the most common type that we come across in mainly in PCO women. And there might be a slight elevation in the LH, and altered FSH-LH ratio might be there. And the use of ovulation induction drugs is the mainstay for treatment here. And in hypergonadotrophic anovulation, that is probably due to POF or premature ovarian failure, we might have to counsel them towards adopting ART. And if hyperprolactinemia is identified and laboratory evidence of raised prolactin levels is seen, and this hyperprolactinemia in turn causes a decrease in the GnRH and also the FSH, and this can be managed with bromocriptine or cabergoline, and this can lower the prolactin levels, and the woman will resume spontaneous ovulation. So what are the drugs that are used in ovulation induction? Clomiphene citrate is the mainstay, has been in the market for over 60, 70 years nearly, and it is the drug against which all other newer molecules are also tested, and it's a time-tested molecule. We also have the option of human menopausal gonadotrophins and recombinant gonadotrophins in women who do not respond to clomiphene citrate alone, or probably for women in the in ART treatment. And the aromatase inhibitors, letrozole and anastrozole, are have also recently, after the ban has been released, are available for the induction of ovulation. But they are not FDA approved per se for induction of ovulation. But it has been, after the lifting of the ban, it has been back into the market, and it is a very promising drug. It helps in monofollicular development, and drugs which facilitate the induction of ovulation, that is insulin sensitizers, mainly metformin. So this can be the first line of treatment even before we start ovulation induction in a couple, in a woman with PCO. And for treating anovulation in PCOS women, the mechanism of action is, if you see PCO women who belong to the euthyroid and normoprolactinemic women who have a normal amount of endogenous estrogen production, the clomiphene citrate is really helpful. So when administered, it tends to act as an anti-estrogen, and it has a inhibition over the negative feedback effect that the estrogen has on the hypothalamus, thus in turn releasing the feedback, and so GnRH is produced, and this in turn causes the pituitary to produce FSH, and thereby triggering the ovulation. So increased GnRH causing increased FSH, and this in turn stimulates the ovulation. So it's also effective in the treatment of short luteal phase, mainly because of deficient FSH. If the corpus luteum is deficient, and this is the CL is, or the Graafian follicle is dependent on the FSH, and when there's a short luteal phase, also the clomiphene citrate might be useful, and it can be used in association with IUI. So in those cycles where we are going to attempt intrauterine insemination, the cycle can be stimulated with clomiphene citrate. So let us look at how we would prescribe clomiphene citrate. Initially, we start with the 50 milligrams, and the lowest dose that we can use to achieve ovulation. That can be best, because if we increase the dose, there's always a higher chance for complications, and the most important being multiple pregnancy. So if we are able to achieve ovulation, then the woman can be asked to continue with the same dose for at least 3 to 6 cycles. But if ovulation is not seen with 50, we can increase the dose to 100. If not, it can be stepwise increased even up to 150 milligrams OD for 5 days. And many women do achieve ovulation with clomiphene citrate 150 milligrams. And the dose is usually started on the second day of the cycle, but can be taken even up to the fourth or sometimes the fifth day of the cycle. And proof of ovulation is by doing the basal body temperature. But if the couple find it very difficult or cumbersome, we have the ultrasound follicular monitoring that can be done. And this is actually the mainstay nowadays. And the various kits that predict ovulation, that is the measurement of the urinary LH. LH kits can also be given for the couple. But the clomiphene citrate, being anti-estrogenic in its action, also has some negative impact on the endocervix and in the endometrium. So when you look at the ovulation rates with the clomiphene citrate, we get almost 80% ovulation. But the pregnancy rates are only around 40 to 50%. And why so? It's mainly because of the negative action of the clomiphene on the endocervix, making the mucus thinner and less favorable for sperm survival. And also the thin endometrium that we see, so the endometrial receptivity may be poor, and this can in fact affect the ovum implantation. What is clomiphene resistance? Actually, it describes women who do not ovulate in response to clomiphene. So we might be able to achieve ovulation, but they might not conceive despite ovulation. So that is, as I said in the previous slide, probably due to the endometrial hostility. But to label a woman as clomiphene resistant, even after 3 cycles of the maximal dose of 150 milligrams, she shows no evidence of ovulation, then we will label her as clomiphene resistant. And clomiphene can be combined with glucocorticoids like either prednisone or dexamethasone in the early follicular phase, and especially so in women where there are elevated androgen concentrations. And the glucocorticoids tends to suppress these androgen, and it triggers the ovulation. And when a cycle is triggered, when a follicular development is triggered with clomiphene citrate, many women, especially the PCO women, they do not have an endogenous LH surge. So we will have to administer HCG to trigger the ovulation. CC can be combined with metformin, and this helps to reduce the insulin resistance. And as I said, in women who do not respond to CC alone, it can be combined with human menopausal gonadotropin, and this can help in reducing the resistance to the clomiphene alone. So what are the main gonadotrophins that are available? We have the menopausal gonadotrophins and the recombinant gonadotrophins, which have purely FSH action, especially in PCO women, where the LH is already at a higher level. They will respond better to recombinant FSH. So the dose can be started in the dose of 50 to 75. A low dose is started and given intramuscularly on the day 5 of cycle, and we can slowly step up the dose depending on the follicular size that we measure on transvaginal ultrasound. And HCG 5,000 international units can be given to trigger ovulation. So this is the step-up protocol for treatment with HMG. We perform a baseline ultrasound and start administering HMG in the dose of 75 or 150 for 3 or 4 days, and measure the estradiol levels. And if it shows a doubling, then we continue in the same dose. If not, we can increase the HMG dose by 50% for another 3 more days. So the initial dose can be either, as I said, raised up to by 150 milligrams or up to 225 international units, and look at the follicular development every 2 to 3 days once. And when the dominant follicle, lead follicle, has reached 14 mm, then it usually tends to grow by itself on its own from the FSH action. And the mainstay or the main goal of our treatment should be to achieve a single pre-ovulatory follicle. But sometimes multifollicular response does happen. And when such a response happens, we have to be very careful so as to not have the main complication of OHSs, or which I will be talking to you shortly. The aromatase inhibitors, as I said, letrozole and anastrozole, have an advantage over the clomiphene citrate, because it does not have the anti-estrogenic effect on the cervix and endometrium. And another important advantage is that it induces monofollicular development. So what are the complications of ovulation induction? One of the most important and dreaded complication is the OHSS, which is characterized by ovarian enlargement, and its most severe form, third space collection like ascites and abdominal distension as a result of this. And when it becomes very severe, leading on to even renal shutdown, oliguria, and pleural effusion. So this is a life-threatening condition. So management will have to be done in tertiary care setup, and most important is to have a conservative way of managing it. Correct the fluid balance and give human albumin, and we try to host the cycle and avoid giving the HCG trigger because it's likely to aggravate the condition. And another complication is the multifetal gestation. As I said, it's a consequence of multiple ovulation. And can we do laparoscopic ovarian drilling? So this is also performed, but in select cases. The rule of 4 is what we follow nowadays. We shouldn't puncture or damage the ovary too much. Just 4 punctures, about 4 millimeters, and the current lasting for only just 4 seconds contact, and only up to 40 watt. The advantage of the ovarian drilling will be seen that the follicular fluid that comes out, and it helps to uh, increase the insulin sensitivity which happens in the intra-ovarian wall, the milieu, and the woman is able to achieve the ovulation. And the advantage of doing the LEOs or the laparoscopic ovarian drilling is, at the same time, we can also test the tubal patency by our chromoperturbation test. And as I said, when it is a hypogonadotrophic hypogonadism, and that's the cause for the infertility, GnRH in a pulsatile dose can be given, but it is expensive. And in IVF, GnRH is usually given in the continuous dose or continuous low dose, which acts to suppress the endogenous LH and also the FSH that might come from the endogenous production. And this mechanism is by the desensitization of the GnRH receptors, which are present on the pituitary gland. And this in turn prevents the premature LH surge and premature ovulation, so that our follicular, the oocyte yield will be much better, especially in the IVF cycles, in the long protocol, especially from the previous cycle itself, the GnRH is begun. And nowadays we've moved towards the GnRH antagonists. They are much advantageous because it can be used for short periods, and they in turn act by directly blocking the receptors in the pituitary gland, and prevents the premature LH surge, and also the endogenous ovulation that might happen in these women who are having exogenous FSH stimulation. So the GnRH, so various protocols are available. That is the ANTAG protocol. And the preparations that are available in the market are cetrorelix and ganirelix, the commonly used GnRH antags. And a word on the emerging role of N-acetylcysteine, which is an adjuvant to clomiphene citrate for ovulation induction. So the N-acetylcysteine is basically used for by the pulmonologist for a mucolytic drug. It also has a proven activity on insulin secretion in the pancreatic cells, and it acts as a insulin sensitizer. Debris et al. Had several studies they had done, and identified the anti-apoptotic activity against of this drug, the N-acetylcysteine, and it also has a protective action against focal ischemia that happens at the level of the ovary, and thereby preventing follicular atresia. So the NAC treatment improves the insulin sensitivity and the endogenous thyroid levels, and also PCO. So the N-acetylcysteine is very effective for inducing or augmenting ovulation in PCO patients. And it promotes, as I said, the lipid profile, and it also helps in ovulation. And the long-term health status of the women with PCO, it does help when administered along with the CC. One of the studies performed by Habib et al. In Kashmir, wherein two groups were randomized to CC or CC plus NAC, and it was found that it can improve ovulation and pregnancy rates in women with PCO, and it does have beneficial impact on the endometrial thickness as well. And since it is well tolerated and safe and inexpensive, it can be an adjuvant treatment in the induction of ovulation along with CC. This is also another study by Badawi et al., which showed a significant difference in the ovulation rates between the CC group versus the CC plus the N-acetylcysteine group. And it was a statistically significant correlation. So the other causes for anovulation, luteinized unruptured follicular syndrome, can be treated with micronized progesterone, or HCG can be administered in the dose of 2000 IU during the and HCG can be used to trigger the ovulation. It can be given at a higher dose to trigger the ovulation. And if hyperprolactinemia is the cause for the anovulation, then bromocriptine, which is a dopamine agonist, can be given at the dose of 1.25 milligrams for a period of 7 days along with the ovulation induction. And hypothyroidism can be corrected with levothyroxine. So looking at the tubal factors for infertility, if it is a proximal tubal occlusion, selective salpingography or a hysteroscopic tubal cannulation can be done, or a tubal microsurgery can be done to do a resection and anastomosis of the level at which the tubal occlusion is there. And even tubocornual anastomosis or a tubotubal anastomosis can be performed. But the results are not very satisfying, especially when we're dealing with very much damaged tubes. So probably the option of going ahead with a salpingectomy and ART will be the better option, especially so when we're looking at distal tubal occlusion. Sometimes when the fimbrial occlusion happens and there is a dilatation leading on to a mild hydrosalpinx, the response to fimbrioplasty or a neosalpingostomy may not be very successful. So we can counsel for salpingectomy and IVF. Looking at the uterine factors, fibroids is the most important cause, and many times we do see patients with pregnancy and fibroids, so fibroid complicating the pregnancy. So fibroids per se should not be the reason or for us to immediately undergo counsel for a surgical option. So until we have exhausted all other non-surgical modalities of treatment, if we have exhausted, then we may give a counseling for myomectomy, especially so when it is a single large fibroid which is probably impinging on the cavity. And generally we do see that with fibroids, secondary infertility is more common. And if that is the case and the woman has recurrent miscarriages, then we can counsel for a myomectomy. And if it is endometrial polyps, polypectomy, either blind or a hysteroscopic polypectomy is the treatment that is very successful. And for Asherman syndrome, that is intrauterine adhesions, can be released by hysteroscopic adhesiolysis. And to prevent readhesions, we can give OC pills, or an IUCD can be inserted inside the cavity and kept for 2 to 3 months. And then the patient is put on OC pills to develop and regenerate the endometrium. But when it is an uterine hypoplasia, the options are not very good. We might have to, or the couple might have to opt for surrogacy. Management of cervical causes. As I was saying, cervical causes play a very minor role in the cause for infertility in women. So if infection and chronic cervicitis is the cause, appropriate antibiotic treatment will be helpful. And if it is due to poor cervical mucus production, and many times it is also due to unexplained infertility, this factor can be surmounted by intrauterine insemination, whereby we bypass the cervix and the processed sperm is directly deposited near the cornu so that the sperms can migrate into the tube. And when there is a immunity, that is the presence of anti-sperm antibodies in the cervical mucus, it is usually a transient phenomenon. So the couple can be advised the use of barrier contraception for 2 to 3 months. And then the antibodies come down and they are able to achieve a pregnancy. Sometimes immunosuppressants like dexamethasone or methotrexate might have to be given, especially when the response or the presence of the anti-sperm antibodies does not come down. And a word on vaginismus and dyspareunia. The initial visit itself, we should look at whether vaginismus is the cause, and the woman, if she's feeling uncomfortable, she should be counseled and she should be taken separately, and a gentle examination should be done. And probably with vaginismus, the woman will need a lot of psychological counseling. So appropriate referral to the psychology department will be important. And the Fenton's operation is usually performed. It's a hymenoplasty, especially when we have a rigid hymen. This minor procedure can be done, but especially this operation should not be opted as when we look at just the rigid hymen, because the male factor also should be evaluated, and only then we have to counsel the woman to undergo this surgery. And if dyspareunia is the factor, there might be local factors like infection, local vaginitis. All that should be treated appropriately, and lubricant jelly such as a KY jelly or a lignocaine ointment can be given. And endometriosis, I would just like to say a few words, because endometriosis per se is a very vast topic. But if we look at women attending infertility clinics and also coming to us with the problem of infertility, anovulation, especially due to PCO and endometriosis, seems to form the bulk of the condition. And that is affecting the women. So if it's symptomatic endometriosis, GnRH analogs can be given, or letrozole, and GnRH analogs for a shorter duration. And once the endometriosis is suppressed, then we can trigger ovulation. But surgical option of doing a laparoscopic excision and adhesiolysis and trying to restore the tubo-ovarian anatomy should be the mainstay of the treatment. And if it is a large endometrioma, large cyst, it can also come in the way of doing oocyte aspiration, especially so when the couple are going for ART. So excision of the cyst, that is drainage and de-roofing of the cyst, and all that can be performed prior to referring the couple for ART. If it is asymptomatic and minimal endometriosis, nothing much is needed to be done except to observe for 6 to 8 months. And if still they are unable to achieve a pregnancy, then we can proceed with the evaluation for infertility. Peritoneal disorders, mainly peritubal adhesions. Most common causes can be due to the endometriosis, especially when it is severe endometriosis, or it can be due to secondary to infection, the PID. So it can be tackled laparoscopically, and laparoscopic adhesiolysis and restoration of the normal tubo-ovarian anatomy is very, very important. And in unexplained infertility, low dose of aspirin, 75 milligrams preconceptually, can also be tried. And generally, with endometriosis and in women with very severe PCO unresponsive to CC or a combination of CC and HMG, the option will be to go in for ART to achieve a successful pregnancy. So a word on intrauterine insemination. This is where the husband gives the semen sample, and the swim-up technique is used to process the sperms, and insemination can be done. Usually it is done intrauterine. Rarely we can even attempt intracervical or intrapericervical. And the direct intraperitoneal is almost obsolete nowadays. And the male partner gives the semen, which is washed and stored, and the woman undergoes a controlled ovarian hyperstimulation. And when the follicle reaches around 20 millimeters, HCG trigger is given, and the IUI is done by introducing the processed semen through a catheter, mostly around 36 hours after the HCG injection. ART is, or assisted reproductive techniques, is all the treatment procedures that involves handling of the oocytes and sperms outside the body. Although we do say IUI does not strictly come under ART, but the other types of ART are in vitro fertilization and ICSI. Olden days, we used to do GIFT and ZIFT, and these procedures are almost obsolete now. Indications for ART will mainly include blocked or damaged fallopian tubes, severe endometriosis, male factor infertility, unexplained infertility or immunological infertility, or a woman with a diminished ovarian reserve, and probably pelvic malignancy, where the need to achieve a pregnancy prior to adopting the appropriate treatment for the pelvic malignancy. We can refer the couple for ART. The main complications of IVF are OHSS, multifetal pregnancy, especially sometimes ectopic pregnancy, and sometimes even a heterotypic pregnancy where you have a combined intra and extrauterine pregnancy, the miscarriage and prematurity, low birth weights, and sometimes even congenital malformations. So the selection before IVF, the ovarian reserve and male factor and infectious diseases and HIV, HBV, HCV, all that should be ruled out, and treatment for chlamydial infection, all that has to be done. And evaluation of the uterus, the endometrial cavity for the receptivity to the implanted embryos. So it can be done by HSG or even a hysteroscopy prior to doing the embryo transfer. ICSI or intracytoplasmic sperm injection is a procedure where a single sperm is injected directly into the egg, and it is mainly for male infertility, where the sperms are cannot be or it's not available in the ejaculate, and only aspiration of the sperms from the testis can be done. There are various treatments for that, like PISA or TISA, and ICSI can be done. And also in repetitive IVF failures, ICSI can be the option which can give success. So indications, as I said, for ICSI is mainly male factor, severe oligoastheno or a teratozoospermia, or when we want to do a pre-implantation genetic diagnosis and a prior failed, as I said, IVF or poor IVF outcomes. So GIFT is wherein the eggs are removed from the woman and placed into the fallopian tube. But this is not usually, as I said, done. We used to do this during my earlier days, which I would say probably before ICSI has now taken over the entire ART scenario. The oocytes are taken and placed inside the isthmus region of the fallopian tube. So the cannulation of the tube is done laparoscopic guided through the fibril end. And zygote, same way, the zygote is then transferred into the fallopian tube. And a word on surrogacy, which is basically defined as the engagement of a woman who will be the person carrying the pregnancy for the intended parents. So the biological parents, that is the embryo, will be from the couple, and the woman will be the surrogate woman will be the woman who is carrying the pregnancy. And strict criteria have been given by the government of India on our in the ART bill as regards surrogacy as well, and all this has to be followed. And it may be intended for conditions like repeated pregnancy losses, or absent or a very diseased uterus, or a uterus which is studded with multiple fibroids and previous pregnancy losses, or some hereditary disease, or failed IVF, or in women with a normal ovaries but probably a hypoplastic uterus. Adoption will be the last resort, but last but not the least, it refers to the legal process of becoming a non-biological parent. And usually the couple would like to exhaust all their own the options available, and as far as possible try to have their own genetic babies, and probably resort to adoption when all other measures fail. So, as infertility consultants, it's important for us to draw the line where sometimes they are driven by uh, the need to have a biological or a genetic their own baby, and counsel them appropriately and very sympathetically, and offer the choice of adoption to a couple who have had repeated failures even with ICSI. And here I would like to say that, especially with the unexplained infertility and all, we have had women, couples, especially after they have chosen adoption as a choice and gone ahead with the process and legally adopted a baby, the couple have achieved spontaneous pregnancy. So that is something like a God's gift, because I would say this is probably due to uh, the stress that the couple are facing with the repeated treatment and the various treatments that they undergo. When that stress is gone out of them, and they divert their attention towards taking care of this newborn, they achieve a spontaneous pregnancy. In my own practice, I have two couples who have had spontaneous conception following the adoption. Thank you, one and all, for a patient listening.
Thank you, ma'am. Thank you very much for that wonderful and detailed presentation, ma'am. Yes, ma'am. If there is any queries, then I will read it for you, ma'am. I request the participants to post your queries. Ma'am, there is one question, ma'am. What is the role of measuring AMH in ovarian tilting, ma'am? How it is related?
See, am I audible?
Yeah, ma'am. Yeah, ma'am.
Yeah. The anti-Mullerian hormone is a measure of the ovarian reserve. And when we look at women, especially women who are over the age of 30, uh, there is, as I said, there is a dwindling ovarian reserve. And the advantage of this test is that it can be performed during any time of her cycle. And when we look at a reserve, or when we look at an AMH value which is less than 0.8, it tells us that the endogenous ovarian reserve is very poor, and she might need a stronger stimulation, or sometimes the chances for successful response to stimulation is a little less. And in PCO women, especially, the AMH will be very high, in fact. So the AMH is also the mainstay in trying to assess the ovarian reserve in women with infertility.
Yes, ma'am. So, ma'am, we have another one question. If a patient is undergoing surgery for this endometriosis, how long she should wait for a pregnancy, ma'am?
If we do a procedure laparoscopically, and as I said, the endometriomas are there, we go in and drain the endometriomas and do a de-roofing, and try and release the adhesions and restore the anatomy. Uh, the best response will be seen, if at all, within the next 3 to 4 months following the procedure. So generally, in women who have undergone laparoscopic procedure, operative laparoscopic procedure for endometriosis, we just ask them to give some time for the skin wound to heal, and also for another couple of months, and then they can attempt pregnancy. So when we are looking at a couple with such endometriosis, usually we don't tell them, we call them up after 2 months itself, and they can start trying for pregnancy after 2 months, or at the most 3 months. And if they achieve a pregnancy, we see that the response is best within the uh, 6 months itself following the procedure.
Ma'am, whether myonostols will be helpful in poor ovarian reserve, ma'am?
myoinositol is, yes, it can be given, but in PCO women, it tends to reduce the insulin resistance, and it also acts in sensitization, and it can be administered. And yes, it's coming up in a big way. So when you want to try in PCO women who are very resistant and who show evidence of hyperandrogenemia, the myoinositol preparations can be used. Yeah, there are various preparations which are available in the form of tablets or sachets. And it has to be also, the most important thing is it has to be clubbed with weight reduction. So appropriate counseling should be given. And just taking the myoinositol alone may not be very beneficial, especially so when we're looking at obese PCO women. But in lean or even ideal body weight PCO women, it helps in the ovulation.
Ma'am, I don't find any other questions, ma'am. So if you allow us, then we can end the webinar for today, ma'am.
Thank you. I would
Yeah,
like to thank Shield and Shield Connect for their continued initiative and in helping the spreading awareness about the various conditions that are affecting women, and also to help spread of knowledge to the amongst the young gynecologists. And thank you once again, Shield, for having given me this opportunity. Thank you, Dr. Stalin. Thank
thank you,
you,
ma'am. Thank you very much for
Naresh.
being with us, ma'am. Yeah, ma'am. We are looking for many more interesting webinars with you, ma'am. So I would like to thank the participants for their active participation, and thank you one and all.
To all the delegates for their active participation.
Yes, ma'am. Thank you. Thank you very much.